Good morning and welcome everyone to the third webinar series of the WHO Regional Office for the Western Pacific and Philippines Country Office on Clinical Management. My name is Dr. Albert Domingo, broadcasting live here from the WHO Philippines Country Office in Manila. And together with me now are my colleagues, Drs. Gary Kuniyoshi and Sophie Dennis. Dr. Gary Kuniyoshi is our pulmonologist, also at the regional office, and Dr. Sophie Dennis is with the emergency department of the regional office. We are here now. Thank you so much for signing up. We are seeing the participant count go up. It's now at 280. In a few minutes, we will be starting with the first of five seminar lecture series. Today, we'll be on clinical management and therapeutics update. So while waiting for the number of attendees to climb, now at 300, just to refresh, today, Monday, August 3, will be about the updates on clinical management and therapeutics by Dr. Gary Kuniyoshi. Tomorrow, Tuesday, August 4, will be oxygen therapy and clinical care in the context of COVID-19 by Dr. Vanessa Yap-Yakapin. On August 5, Wednesday, will be co-infections and the use of antimicrobials in the context of COVID-19 by Dr. Jyoti Somani. And then August 6, Thursday, will be patient safety and healthcare worker infection and prevention by Professor Kok Hyun Tan and Ms. Tan. And then on August 7, Friday, will be the role of primary and community care in the COVID-19 response by Dr. Donald Lee. So there are now 317 participants, and our format has always been the same. The presenter will be speaking for 30 minutes, after which there will be a 30-minute window for questions and answers. Those of us who are here on Zoom may use the Q&A button, which you will find at the bottom of your screen. You can type in questions even while the presentation is going on. Don't worry, they will be logged. If you see a question from someone else that you think you'd like to join, you can upvote the question and the moderator, that's me, will see it faster so that we can ask it from the presenter. All right, so Dr. Gary Kuniyoshi will now take the floor. Gary, over to you.
Thank you, Albert. Are you able to see my slides?
Yes, and we can hear you clearly.
Thank you. Good morning, everybody. Today I'm going to be talking about the clinical management and therapeutics update. I'm going to be covering 4 different topics: use of systemic corticosteroids, severity of disease, pregnancy risk with COVID-19, and also the issue of positive PCR testing after recovery. We're going to be covering a lot of the science behind this. The clinical question of what is the role of systemic steroids in the treatment of hospitalized patients with COVID-19? The current situation is corticosteroids are receiving worldwide attention as a potentially effective treatment for COVID-19. This was triggered by a report from what's called the recovery trial for dexamethasone in hospitalized patients. So corticosteroids or steroids are readily available medicines and have been used in the treatment of various severe acute respiratory conditions and infections, including asthma, chronic obstructive pulmonary disease exacerbations, ARDS, pneumocystis pneumonia, and severe community-acquired pneumonia. So this is the current WHO guidelines, and this is a slide from the Open WHO Clinical Care course that's available online. So this is currently the slide that is available. This will change. So let's go through what is currently on the WHO guidelines. It says, do not routinely give systemic corticosteroids for treatment of viral pneumonia outside of clinical trials. Again, this guidance will change. There are some well-recognized adverse effects with use of corticosteroids, including hyperglycemia, infections or secondary infections, bone necrosis, delirium, and all of these can be associated with increased mortality. In other outbreaks of novel coronavirus infections, corticosteroid therapy was associated with delayed virus clearance or prolonged viral replication. This is a recognized finding with both SARS and MERS. So this was a trial on the use of corticosteroids that was reported in the New England Journal of Medicine. It was first published online July the 17th, 2020. Dexamethasone in hospitalized patients with COVID-19. This was called an preliminary report. So the Recovery Collaborative Group, this is a study out of the United Kingdom. It was a multi-center study, about 176 different centers. It was an open label study, which means it was non-blinded. It was a randomized controlled trial with about 4,300 patients randomized to usual care and 2,100 to experimental treatment, which was the dexamethasone. The dexamethasone was 6 milligrams per day for up to 10 days. And the primary outcome that they were looking at was all-cause mortality or survival at 28 days. And just a little additional information, the mean age of the patients in this study was about 66 years, and roughly half of the patients in the study had some type of coexisting disease, about 20% diabetic, about 20% with significant heart disease, and around 20% with chronic lung disease. So the primary outcome that they were looking at was 28-day mortality. That is alive at 28 days from the time of entering the trial. So you see this graph, and this is known as a rate or risk ratio. You see a vertical line there at 1.00. The more you go to the left, that indicates dexamethasone was better. The more you go to the right, it indicates usual care was better. So the first line, those are patients that received invasive mechanical ventilation. This is about 1,000 of the patients. And you can see toward the left, you see where that square, that dark square is at with a line through it. That showed that dexamethasone was much better in this first group that was on mechanical ventilation. Next, the second line are those patients that were on oxygen. And you see it's a much bigger square because it's about 4,000 patients. And it is toward the left, but not as much as the group with mechanical ventilation. So those patients on oxygen, they did do better, but less so. Then the third line, those are patients on no oxygen. And you can see it's actually toward the right, where the usual care was better. This is about 1,500 patients. But you can see that horizontal line crosses the 1.00, which means it was not significant. So the effect of dexamethasone on 28-day mortality. So those patients on invasive mechanical ventilation, so the mortality in those receiving dexamethasone was 29% and 41% in those not receiving dexamethasone. This was a reduction in death by about 36%. I'm sorry, 32%. Those on oxygen, the mortality of those receiving dexamethasone was 23% versus 26% in those not receiving. So the reduction in death by about 18%. Those receiving no oxygen, there was no significant difference. The secondary outcome that they looked at, remember the primary outcome was 28-day mortality or survival. The secondary outcome was discharge from hospitalization. So the median duration of hospitalization in the treatment group, those that received dexamethasone, was about 12 days. And those receiving usual care was 13 days. So this also showed a greater probability of discharge to home alive within the 28 days. So for patients on mechanical ventilation, dexamethasone reduced mortality by about 1/3, or about 32%. For patients requiring only oxygen and receiving dexamethasone, reduced mortality by about 1/5, or about 18%. For patients on no oxygen, there was no benefit. There are several limitations from the study. It was an open label study, so it was not blinded. And then the investigators also reported that because they entered patients that were suspected, as well as being confirmed of having COVID-19, that up to 11% of the patients could have had a negative PCR test for COVID-19. So what is WHO's current position on the use of dexamethasone? So does WHO recommend the use of dexamethasone for COVID-19 patients? So currently, WHO is in the process of updating the treatment guidelines to include dexamethasone or other steroids. So that is currently in process. So does dexamethasone work against COVID-19? So it was tested in hospitalized patients with COVID-19 in the United Kingdom National Clinical Trial called Recovery, and was found to have benefits for critically ill and severely ill patients. So patients both on mechanical ventilation and patients on oxygen. So there are some additional considerations regarding steroids. So these are not the WHO guidelines. These are some other national guidelines. This is the United States National Institute of Health guidelines. And the US NIH guidelines does recommend using dexamethasone for patients with COVID-19 who either require mechanical ventilation or who require supplemental oxygen. These guidelines also list some additional considerations, and one of these is other corticosteroids. So at this time, it is not known whether other corticosteroids such as prednisone, methylprednisolone, or hydrocortisone will have a similar benefit to dexamethasone. So at least some dosing adjustments should be considered. Another consideration is pregnant patients. So very few pregnant patients with COVID-19 were included in the recovery trial. Therefore, the safety and efficacy of using dexamethasone in these patients is really not known. Steroids such as betamethasone and dexamethasone are used in pregnant patients without COVID-19 routinely to hasten fetal lung maturity and thought to be safe. The US NIH guidelines does recommend using dexamethasone in pregnant women with COVID-19 who require mechanical ventilation and are on supplemental oxygen. Another consideration is children. So very few pediatric patients with COVID-19 were included in the recovery trial. Therefore, the safety and efficacy of using dexamethasone in these patients is also unknown. It should be noted that mortality rates are significantly lower for pediatric patients with COVID-19. As an example, the US NIH guidelines states dexamethasone should be may be beneficial and should be considered on a case-by-case basis in pediatrics. Generally, it's not recommended for pediatric patients who require a low level of oxygen, and by that, the NIH means on nasal cannula only. It should be noted that in the recovery trial, a number of patients were not enrolled into the dexamethasone study if their physician decided they were not suitable for any reason. So similarly, before initiating dexamethasone, clinicians should review the patient's medical history and assess the potential risks and benefits of administering corticosteroids to the patient. Another recommendation to highlight is the United Kingdom's National Health Service, or NHS guidance, which also recommends dexamethasone. They use an additional consideration of close monitoring. Close monitoring of patients who are receiving dexamethasone for adverse effects. And these adverse effects could be things like hyperglycemia, secondary infections, or GI bleeding. And specifically, the NHS guidance says consider adding gastric ulcer protection, such as a proton pump inhibitor, according to your local hospital policy. And the last consideration is co-administration. Other medications such as remdesivir were not part of the treatment in the recovery trial, and therefore the safety and efficacy of co-administration of these two drugs together are not known. So dexamethasone is what's called a moderate cytochrome P450 inducer. So this in these drugs that are metabolized by the liver, it may reduce the concentration and potential activity of medications like remdesivir. And then the other direction, remdesivir is a P450 inhibitor and could increase activity of dexamethasone potentially, but this is not likely to have a significant effect. So in summary, the recovery trial did show dexamethasone reduced mortality among COVID-19 cases or patients with COVID-19 who were either mechanically ventilated or required oxygen. Again, use of dexamethasone in hospitalized patients, the most benefit is in those on mechanical ventilation and less benefit for those on oxygen and no benefit for those not on oxygen. WHO is currently undergoing a guidelines update, and there'll be a supplement to the current clinical management of COVID-19 guidelines, which can be found online. And the limitations and unknowns about steroids and COVID-19 must be recognized, and these additional considerations such as other types of steroids, use in children in pregnancy, and co-administration and the adverse effects must be recognized and addressed. So the second question is about severity of disease. So this question has been observed sometimes globally. It's the observation from clinicians that they are seeing fewer severe COVID-19 cases, leading some clinicians to question, is the COVID-19 disease changing? Is it becoming less severe? So this is what we understand about the natural history of the disease, primarily from the Chinese CDC data. So these patients were all hospitalized. About 40% developed mild disease, 40% developed moderate disease or pneumonia not requiring oxygen, and 15% developed severe disease or pneumonia requiring some level of oxygen, and 5% developed critical illness. This does not address the question, how many have asymptomatic disease. Probably the best estimates we have with some limitations are from cruise ships. An example is what's known as the Diamond Princess. The severe or critical or fatal cases of those with symptomatic disease was about 13%. This is not that dissimilar from the 15 to 20% from the Chinese CDC data. The asymptomatic rate from the data from the Diamond Princess cruise ships was actually close to 50%. Again, this is a cruise ship population, and they may be older, but possibly healthier than the general population. A systematic way of looking at disease severity, considering some of these factors, such as viral factors, host factors, clinical and epidemiological factors. So looking at viral factors, the viral genetic sequence data, this is a diagram of what's known as a genomic phylogenetic tree of COVID. So the Global Information Sharing, or what's known as GSID, they record the genetic sequences from patients with COVID all over the world. And then they put these into groups or classes, these different colors that you see here called clades. They have noted no rapid change in the clade distribution. There is one particular mutation called, is from Europe, called the D614G. This mutation tends to dominate over time when it goes into different locales. But this mutation is not thought to be associated with a change in virulence or change in severity. Further on the viral factors, GSID also does surveillance of receptor binding mutations. And since SARS-CoV-2 is a relatively long virus compared to others, with other characteristics, it makes it quite stable and less prone to mutation. So these are little illustrations of the spike protein of the SARS-CoV-2. The illustration on the right, you see a little green color at the top. This represents the ACE2 receptor on the human host. This is found in human lungs, the heart, kidney, GI tract. Currently, there's no new mutations in receptor binding and nothing to suggest change in transmissibility or severity. Then we have clinical factors. There are some advances in treatment. We talked about dexamethasone, but unclear how widespread use has been. Remdesivir, it is a treatment that targets SARS-CoV-2, and in the latest literature, it shortens time to recovery by about 4 days, but not mortality. There are other types of supportive treatments, such as anticoagulation, which is receiving wider use. All of these may benefit morbidity and mortality, but hard to quantify and unclear how substantial. So I'm going to quickly go through a UK case study looking at seeing if severity has changed, because this is where we have some of the best data. So age is a well-recognized risk factor for COVID illness. One hypothesis is that younger patients are contracting COVID. This is a comparison from April to June by proportional rate by age. The age proportions are quite similar. So there was not an increase in younger patients contracting COVID-19. In one particular week, there was actually an increased proportion of older patients. There's more cases in the greater than 70 years old group. So in the UK case study, age does not appear to be a significant factor. So further on the UK case study is a number of tests performed a factor. The graph on the left are the daily confirmed COVID cases from January to June. You see a steady peak and then a steady decline. The graph on the right shows daily tests performed from May to June, a very stable number of tests since May. So in the UK case, there's a steady decrease in case numbers, and the amount of testing performed is stable, does not appear to be a factor. Further on the UK case study, the graph on the left is a daily positive tests from May to June, again, a progressive decline. The graph on the right is a case fatality rate, and it's relatively stable since April. So in this United Kingdom case, progressive decrease in patients presenting and testing positive. At the same time, the fatality rate have been consistent over the last several months. This appears to indicate that the severity of disease is not changing. So in summary, some clinicians have made the observation that there are fewer severe or critical cases. And the question is the disease changing? Their observations may be due to many reasons, as disease severity is affected by many factors. They could be viral and host factors, but these are not likely to have changed. Clinical factors may have contributed, but not likely to be substantial at this point. And epidemiological parameters, at least in the UK, seem to indicate that the severe disease is not changing. So it's possible that clinicians have this impression due to a decrease in number of cases with less burden in the healthcare field. So taken together, considering factors and epidemiological parameters, these indirectly suggest disease is not changing. Okay, I'm going to quickly go through our third topic, which is, are pregnant women with COVID-19 at higher risk? This has received some increased media coverage recently. So this is the question, the background. Are pregnant women with COVID-19 at higher risk of severe clinical manifestations and adverse pregnancy outcomes? We have a range of other infections, such as malaria, listeriosis, and herpes simplex virus, where pregnant women do have increased susceptibility and severity. So this is what's on the current Open WHO clinical care course. This is the current WHO guidelines, which says there's no evidence that pregnant and postpartum women with COVID-19 infection present with different signs and symptoms or at higher risk of severe illness. So this may be updated. So very quickly, the impact of other respiratory infections on pregnancy. So historically, women with respiratory infections were at greater risk of severe maternal and neonatal morbidity and mortality. And some of these examples include the influenza pandemic, the Asian flu pandemic, SARS, and MERS. They all were associated with a greater risk of either maternal or neonatal morbidity and mortality. So there was a large systematic review that looked at 86 studies. So these were all published before June the 8th. And it did show that preterm birth was common. About 22% of the deliveries in pregnant women with COVID-19. About half the patients did receive C-section, and COVID-19 was listed as the most common indication. And then about 70% of the pregnant women with COVID-19 required ICU admission, and about 3% required intubation. And mortality was not common, it was about 1%. The US CDC reports, this was the first major study to suggest pregnant women were at higher risk of severe disease because they were more likely to be hospitalized and more likely to be admitted to the ICU. Again, this is from the US CDC study. So after adjusting for age and underlying conditions, pregnant women were about 5.4 times more likely to be hospitalized. They were significantly more likely to be admitted to the ICU and significantly more likely to require mechanical ventilation. There was no difference in mortality between pregnant and non-pregnant women. Again, this is the US CDC study from June. Between January 22 and July 21, there are about 12,900 cases of COVID-19 in pregnant women in the United States, with about 35 deaths. And about half of them were in Hispanic or Latino women. So there was an overrepresentation of certain ethnic groups, highlighting the population aspect of looking at this data. So in summary, populations at higher risk of COVID include older age, obesity, other comorbidities, and it may include pregnant women. So we have some literature that seems to indicate this. These are the other things on this summary are important things to keep in mind when treating pregnant women with COVID-19 disease. So this is not currently updated yet, but looking at the literature, it may be. So the last topic I'm going to cover is positive PCR results in recovered discharged patients. And the question is, are these patients infectious? So the current WHO guidelines says to discontinue transmission-based precautions, also known as discontinuing isolation precautions, or could be discharge criteria if it's the same. This does not require PCR testing. So for symptomatic patients, 10 days after initial symptoms onset and at least 3 days without symptoms, which is fever and respiratory symptoms, then you can discontinue isolation precautions and or discharge. So what is the problem that we've been hearing? So the problem is that several countries have reported some patients who have recovered from COVID-19 went on to develop positive RT-PCR results after discharge. So there are several questions come up. Are these recovered patients still colonized with coronavirus? Is it possible that these are relapsed illnesses, or are they reinfected? Or is there evidence that indicates these patients are infectious? So also on this, WHO does not currently have a specific recommendation on this. However, this may be updated in the upcoming guidelines. So let's go through some of the data in the literature. These upcoming slides contain some charts and graphs from studies, but I'm going to cover some of the highlights. So RT-PCR results can fluctuate or be highly variable during the time the patient is in the hospital. So this is a study from China where 14 patients had 2 consecutive negative samples and then tested positive and negative, then positive and negative, 5 to 13 days post-discharge. In another study, about 610 patients from China demonstrated RT-PCR, which fluctuated or were highly variable during the hospital course. So what is the duration of PCR positivity? These are very busy graphs, and they show what's known as cutoff values versus symptom days, but let me go through some of the key findings. The initial high viral burden measures from the nasopharyngeal titers declines steadily after the onset of illness. So following recovery from clinical illness, many patients no longer have detectable viral RNA in upper respiratory specimens. But there are cases of prolonged viral shedding. A study from Wuhan reported that virus was detected for a median of 20 days and up to 37 days among survivors. An often cited German study of 9 patients with mild COVID-19 demonstrated that no samples taken after the 8th day of symptoms were positive by cell culture. So they were not able to isolate any live virus, even though the RT-PCR method was positive. The Republic of Korea has looked at their cases that have been positive after discharge. They are calling these repositives, and they studied or tested about 100 consecutive patients, and all the viral cultures were negative. So the detection of viral RNA from a respiratory sample of a recovered person does not necessarily mean the patient is infectious. The RT-PCR diagnostic assay only detects the presence of viral RNA, not infectious virus particles. So it's important to remember that laboratory results must always be interpreted within the clinical context. So lastly, what can we learn from other infections? What we can learn from other viral infections such as measles is that measles virus RNA has been detected in multiple sites for up to 3 months after infection in a proportion of infected children. So viral RNA was found to persist in blood, respiratory tract, or lymph nodes 4 to 5 times longer than infectious virus. And these patients, at least in the measles context, are not considered to be infectious. So in summary, regarding the positive PCR results in recovered discharged patients, there is currently no direct epidemiological evidence that these patients are infectious. And from what we currently know, based on some recent data, it seems that these patients are often expelling material from their lungs as part of the recovery phase. We quickly go through some of the discontinue transmission-based precautions or discontinue isolation precautions. These can also be discharge criteria for patients in the various countries in the West Pacific. So all these countries listed here, they updated their discharge criteria, and they do not currently require PCR testing to discontinue isolation precautions. They include Brunei, Malaysia, Japan, Philippines, and Singapore. And this is a quick summary of the updated discharge criteria for these countries. So Philippines required 10 to 14 days. Singapore, greater or equal to 21 days. Malaysia and Brunei, at least 14 days after onset of symptoms, and Japan, at least 10 days. Please refer to your country's clinical management guidelines or guidance for the either release from COVID-19 pathway, also called release from isolation, or discharge criteria. So this is the end of my presentation. Thank you for listening.
Thank you, Dr. Gary. Very informative as usual. And for those who have just tuned in, this is actually the third of a series of webinars. There will probably be more as the evidence comes. And I'm just saying that to answer because there was one question already. There are now, I think, 17 open questions. But that question which asked, so how often does WHO update its guidelines? And I did mention that as soon as strong evidence is available, the WHO gets to work immediately to update their guidelines. So just to get the ball started, there are already quite a number of questions. We are full in the Zoom room, 500 participants, but not to worry, there's a spillover of around 30 something participants over in the YouTube, and you can use the live chat over there. I will be monitoring both sides of the internet, so to speak. So maybe Dr. Gary, let's start off with a question. There have been a few asking about this reported claim from a doctor in Texas, not to generalize everyone who is in Texas, but it just so happens that there's a doctor in Texas who came out on social media and said that inhaled budesonide can help out with COVID-19. What's the take of the WHO on that? Gary?
So currently the recommendation for use of steroids is not out from WHO. It should be out coming this week. In the study, they used dexamethasone. You can use, in the study, there was an option for using either IV or oral corticosteroids. There was not an inhaled corticosteroid that was part of the protocol. I do not think that they're going to include inhaled corticosteroids as part of a systemic corticosteroid type of regimen. If that's the question, is about using inhaled corticosteroids?
Yes, that's right. They're asking about inhaled corticosteroids, specifically budesonide, because there's a claim that came out. So just to remind everyone, we still do not have evidence on that. And as Dr. Gary mentioned, there will be a more comprehensive guidance on steroids that WHO will be releasing soon. So I'll just bridge over to a question from Cyflor Putong, who is asking, is multisystem inflammation a direct effect of COVID-19?
So the question is about the multisystem inflammatory syndrome in pediatrics and adolescents. Is that the question? If that's a direct, if there is a known recognized link between that and COVID-19, is that the question?
Yes.
So as far as I understand, that link has not been definitively made. So if you do see any of these cases, there is a case record form that is recommended that you fill out and submit. That's available on the website. There are more and more cases that are being reported, but whether or not this has been definitively linked as a sequelae or result of COVID-19, we do not have any guidance on that as of yet.
Right. I just wanted to echo something that you said, Gary. So this is also a two-way learning process. WHO gathers the evidence, and from where does the evidence come from? Of course, from practitioners, the systematic studies, and also each and every, we have around 500 plus participants here, mostly physicians and nurses who are at the front lines. And this is the importance of reporting what you find out from your practice. Of course, through the usual channels, that's what Dr. Gary mentioned, there will be reporting mechanisms within your hospitals for sure, so that that evidence will be accessible to all and can be properly evaluated. All right, a quick question from Catherine Alibudbud. In the study mentioned, I think she is referring to the recovery study. How many days was dexamethasone administered? So the treatment arm, how many days was dexamethasone administered?
So in the study, it was up to 10 days, but it could have been shorter because they discontinued it at discharge. So the average number of days that patients received dexamethasone, I believe was about 7. But the protocol that they used was dexamethasone 6 milligrams a day for up to 10 days or until discharge.
All right. So I'm looking at the chat room and I see some participants raising their hands. If I lower your hand, it doesn't mean you're not welcome. It only means please use the chat box, the Q&A box to ask your questions so that we can see it along with the other questions. All right. So there are a few questions here. Perhaps this summarizes it. An anonymous attendee asks, Dr. Kuniyoshi, what are the evidences or evidence that giving steroids might delay viral clearance? Interesting question because so far we've been discussing the beneficial effects. So there are a few questions, but there are also some supposed claims that it delays viral clearance. Hence, it's best not to give when the patient is still viremic. What's your comment on that? What's our position on that?
So that was a specific finding with both SARS and MERS. So SARS-CoV-1, not SARS-CoV-2, not for COVID-19, but for SARS and MERS, delayed viral clearance was found in several studies for those other coronavirus infections. As far as I know, that has not been a specific finding with SARS-CoV-2 or COVID-19 thus far.
All right. Practical question from Ryan Vergadero. Should dexamethasone be discontinued in adult patients who started with low flow oxygen therapy and dexamethasone, then was able to tolerate room air after a few days during the course of a therapy? So we're seeing improvement. And I think the question is saying, do we now discontinue dexamethasone?
I think that's a good question. I don't know if we have the answer to that. I believe in the study, they did not discontinue the dexamethasone if the patient came off oxygen. So what they did was they continued the patient for 10 days or until discharge. I don't know if we have a specific answer to that. Yes, that will be something that has to be addressed in your own protocol, that how to use dexamethasone. If the patient comes off oxygen or gets extubated, are you going to discontinue dexamethasone?
Right. Thank you, Dr. Gary. Just a few administrative announcements. So one of the participants is asking, in case the Zoom room becomes full, are we going to be able to see this on YouTube? The system should automatically log you in to the YouTube live broadcast in case the Zoom room becomes full in the next few days. All right, and we'll also be sending out slides and the recording of the presentation as at the end of the day usually. All right. So there are still a few questions on treatment, but this will be the last for now, and then I'll shift over to testing. But last for treatment, two questions are asking just to verify or confirm. What's the position of WHO or the research or evidence on the use of hydroxychloroquine?
So any other kind of specific pharmacological therapy, its use is only recommended under a research protocol. That's currently still WHO's guidelines. The one on the specific guideline on dexamethasone, there will be an update on that coming out of the guidelines. But for all other treatments, it would still be use is only recommended under a ethical research protocol.
Thanks for that clarification, Dr. Gary. So we're now shifting to questions on testing. I will read first the question from Claudia Soriano and provide a bit of context so that we will be able to chime in on what the response is. So Claudia Soriano is asking if an employee got a positive result in rapid testing, but negative on swab, is there a Philippine DOH guideline on how to handle those? Even if even if the swab is negative, would the patient still need to be quarantined? How many days before allowing to go back to work? So the context behind this, Drs. Gary and Dr. Sophie, is in the Philippines, we are seeing the use of both the rapid antibody-based test and also the PCR test, which is more popularly known as the swab test. So can you give us, by way of answering Claudia's question, what's the use of an antibody test or a rapid test, and what's the use of the PCR test, and which one should be used for screening, and so on?
So I'll also let my colleague Sophie speak also. But let me, currently the WHO guidelines does not speak to use of any type of rapid testing in its protocol. If you have a suspect case and they have a positive rapid test, because it doesn't speak to that, or they have a negative rapid test, there'll still be a suspect case. So you would still put them in isolation, treat them that way. In order to be a confirmed case, then you'd have to use PCR testing to confirm. Currently, yeah, there's no specific guidelines on using any type of rapid test.
Dr. Sophie, anything to add on that?
Thanks very much. Yeah, just to add or to complement what Dr. Kuniyoshi has just said, antibody testing yet does not have a role. We don't know what its position is, and definitely is not used to confirm or rule out an active sort of disease progression. So we do not recommend its use. Thanks.
All right. Now, the next question comes from a familiar name, always welcome, and nice to see you joining us, Dr. Sibel Abad. So Dr. Sibel Abad is actually in the webinar as a participant, and she is asking a question which definitely we need to work on in WHO and maybe ask for help also from their group. So Dr. Sibel says, great talk, Dr. Gary, on special populations such as healthcare workers infected with COVID-19. Would you recommend a test-based strategy or a time-based strategy for return to work? It's been a very difficult decision for us with much debate. Dr. Gary, and then Dr. Sophie.
Okay. Let me see if I'll let Dr. Sophie answer that one. I actually don't know the answer to that. That's a very good question, very important question, but I actually don't.
Thanks very much. Yeah, so nice to see you here, Dr. Abad. Just to comment on that, so what the WHO is recommending is moving towards a time-based strategy rather than using test-based. As Dr. Gary presented in his presentation and touched on briefly, is the fact that PCR positivity can continue, and the last point at which we know there has been tested live replicating virus, we haven't found that after 9 days from when the symptoms have first onset. So what we are recommending at the moment is 10 days from when the symptoms first started, and then plus a further 3 days of symptom resolution. And we suggest this sort of because it's looking at the evidence base that is out there, taking that forward. There should be no difference then in its role with regards to healthcare workers sort of returning to work. There is, and you should look at the policies that are in place at the moment. There are certain populations that you need to be slightly more careful with in terms of returning to work with those that are immunocompromised. And whilst there is widespread transmission, we do recommend using masks even with populations that aren't suspected or confirmed COVID-19, especially of those vulnerable populations, so those who are immunocompromised or of such. Thanks.
Great. Chitina de Ocampo Santiago, sorry, I'll skip that. I'll come back to your question again, Dr. Chitina. Okay, here we go. Edwin Paul Dungo. So Edwin Paul Dungo is asking, some of the COVID patients who were discharged without undergoing RT-PCR testing underwent rapid testing, which revealed positive results. What will be your management? So I think this is the fear in the field, the apprehensions that if you use the time-based strategy and then they turn out positive on antibody testing, what will be the management? So what's our comment on this, Dr. Gary and Dr. Sophie?
Thanks. I'll go ahead. So it's slightly muddying the water to use this term rapid test, because we use the rapid test PCR, and then you have the rapid test serology. As mentioned previously, we don't have a role yet for serology testing, especially when sort of determining whether a patient is cleared from the virus. The antibody testing, in terms of what it's looking at from the immunological point of view, is actually ascertaining whether they, or confirming that they had at some point have had COVID-19. So its role really isn't there, or it's just reaffirming that they have had that disease process happen. Thanks.
Dr. Gary?
So the discontinuing the transmission-based precautions, it's based all on time, on symptoms. So the time 0 is actually the time that they first started having symptoms. So it's not necessarily any kind of test per se. So whether or not they tested positive at a certain time or not, you would still use the 10 days after the first symptoms, plus 3 days without any symptoms, which is fever or any respiratory symptoms. So a total of 13 days, according to the WHO guidance.
And then just to add to Gary's comment from that side of things, if for some reason a patient does have a PCR test that is positive but hasn't had any symptoms, then you would take the time at which the PCR was taken as the first day to start the 10 days. Thanks.
All right, the time is 11:52, but the questions are really good, so we will keep on going. I'll ask a quick question first, and then something a bit controversial, but still necessary to be answered. So Dr. Cristina Pasqua is asking, this is the quick question. Are frontliners exposed to confirmed COVID patients, for example, anesthesiologists intubating patients? Should they have routine PCR tests? So should high risk, I'm using the word loosely, should high risk frontliners who are routinely exposed to procedures that can cause transmission of COVID, should they have routine RT-PCR tests? Dr. Sophie?
Thanks very much. Good question, very interesting, debated sort of on a global timeframe. What they're wanting to really do is look at a risk assessment approach. So if you are performing intubation, which we know can be an aerosol generating procedure, if you are wearing the correct personal protective equipment within the right environment at the right time, and you are putting it on and taking it off safely, then you have that protective barrier, which would mean that you're in that low risk category. If there's been any breach in terms of that, then you would be considered high risk, especially since it is an aerosol generated procedure. Everyone should have their own guidance, but what we would recommend is then talking to occupational health and to your governing body, removing yourself from the work environment for 14 days. So quarantine, not isolation, but quarantine, and looking out for any symptom development during that time, and keeping your team informed. If you develop symptoms, that's when you then would consider doing the PCR. But at this moment in time, we're not recommending doing routine PCR testing. Thanks.
Dr. Gary, anything to add?
No.
Okay, all right. So here comes the next question. Margot Kidlat is asking, according to the guidelines in the Philippines, patients are no longer required to repeat PCR tests. So I think that this is the premise. So Dr. Gary did show that the Philippines has adopted the time-based strategy. Now, the current question is, we currently have an issue regarding a sudden increase in the epidemiologic number of recovered patients using the label recovered. The question is, are these patients who are considered discharged from COVID precautions or isolation also considered or can be considered recovered? So is discharge from isolation the same as recovery? That's, I think, the summary question. Who wants to answer? Dr. Sophie?
Thanks. Good question, and I'll pass over to Dr. Gary because he looks like he's unmuted as well. Just to say, so the patient may still require to remain in hospital for medical attention or medical care, but in terms of the precautions that the healthcare workers need to use, we would be then taking a step back. That being said, at the moment with widespread community transmission within the healthcare setting, we would still be suggesting the use of medical masks and contact precautions. So it does change how you approach the patient, and in terms of cohorting, they may be able to go onto the general ward. They're then not deemed to be infectious anymore, but they still may require clinical management or clinical care. Dr. Gary?
Dr. Gary?
So that's why, so WHO uses the term release from COVID-19 pathway because these patients, it only pertains to whether or not they need to be in isolation because they may not be fully recovered. They may need rehabilitation. And so all these things, come into play. They may still be in the hospital and still may need hospitalization and physiotherapy. They may need some other kind of speech therapy. But whether or not they need to be in isolation in a COVID unit, that's what being on the COVID pathway speaks to.
Thanks, Dr. Sophie and Dr. Gary. And from a health systems perspective, I just wanted to add that is an important distinction because we may have more capacity on the non-COVID pathway, which means we still use medical masks, but not N95 masks. We still wash our hands definitely, but we don't use goggles. I mean, it depends on the situation, and this may allow us to free up much needed resources, not only beds, but also human resources. There's an ongoing discussion that don't just discuss the bed, but also the people who are manning or running the bed, so to speak, the ladies and gentlemen who are out there operating on treating the patients rather. So very important discussion. These patients can be discharged from isolation, but they may still need other interventions to facilitate their complete recovery. All right, a little bit more on testing. The time is 11:57. Maybe let's do a little speed dating rapid question thing. What is WHO's view on pooled testing? So there's a new development coming out, pooling samples together, supposedly to increase the efficiency of testing. Do we already have something on that, Drs. Gary and Dr. Sophie? They're waiting on each other, Dr. Sophie. Okay, Dr. Sophie, you first.
Can I just ask the clarification on the question? Is this talking about mass testing, or is this about taking multiple samples from one patient and pooling them together?
It's about taking multiple patient samples, so many people together and just putting them in a batch, like batch testing. Okay.
My understanding, and I'll defer to Dr. Gary, is that we don't recommend this. What you're wanting to be doing is really looking at the case criteria and classifications and really testing on a case-by-case basis. Dr. Gary?
Yes, I still don't fully understand the question. Is about, because it was mentioned batch testing. So you get a lot
Okay. So let me clarify. So for example, there are 10 patients, different locations, but 10 patients. And then the premise is there's a lack of resources and we want to get more people tested. So what the proposal is saying is get the samples of all of these 10 patients, mix them together, test them RT-PCR. If it comes out negative, then all of them are negative. If it comes out positive, then we break down the test and get samples from each of the 10 to check out which of the 10 are positive. That's the concept of pool testing as it's being proposed. Do we have a position on that, Dr. Gary?
No, I believe as Dr. Dennis said, yeah, we do not recommend that. But that's very interesting. That's actually the first I've heard of that strategy. Thank you for that.
All right, all right. So for now, we still do not have a position on that, but maybe, who knows, in the next web advertising, in the next webinar series on the 4th or the 5th, we will have. All right, will WHO release a recommendation for pre-operative clearance or PCR testing? And there's another related question. What's our position on requiring PCR tests for all admissions? So this is like a precautionary measure. What's our position, Dr. Gary, Dr. Sophie?
So I think it really depends on the rate of transmission in the community. So I am aware, and I would have to check. So I tentatively want to sort of refrain too much because they are coming out with some guidance specifically with regards to sort of surgical procedures, so preoperative. But it would have to be based on the capacity of the hospital itself and also of what's happening within the community. If there is widespread community transmission, if they don't have capacity, they may be wanting to use precautions sort of suspected cases with the known asymptomatic presentations as well.
Right. So the time is 12:01, but there is just one last question which I wanted to ask on behalf of Mark Christopher Pasayan. So Mark is asking, after hospitalization and the patient's discharge, they would still be advised to continue home quarantine for 14 more days. So I think this is the current guideline. Does this still apply in the new recommended discharge criteria by WHO? So just to recap, you have a patient who is discharged and then advised to continue home isolation, or because it's a patient, home isolation after discharge from the hospital. Is this still the same under the new discharge guidelines? Over. Dr. Gary?
So the WHO guidance is going to say when you can release the patient from needing isolation, not when the patient should be leaving the hospital. So the patient might be released from the hospital and they still may require X number of days to be in isolation, according to the 10 days plus 3 days. So they may be released home and they may be required to have some additional days. If they're released from isolation, when they go home, they don't need to be in isolation anymore. Not for as a patient.
Dr. Sophie?
Yeah, it's really the same message. Say that from a WHO standpoint, once you have been cleared and you are no longer requiring isolation, you therefore wouldn't require further quarantine when you get home. But as Dr. Kuniyashi did say, you may be released home depending on capacity in hospital and the management of patient flow. You may be released home if it's mild or you're not requiring hospital care before that isolation period is over. And in that instance, you're in isolation, not in quarantine. So the difference is you have confirmed COVID-19, you need to be in full isolation. The quarantine process of 14 days, it isn't what we would recommend, but if at the moment may still be within overarching governing guidance that may need to be adjusted. Thanks.
All right, so just to wrap things up, I just wanted to dwell a bit more on that answer, just so that we are clear, especially among Philippine colleagues. So there are two things we are looking at: the site of the patient, where the patient is, whether inside the hospital or at home, and the condition required for isolation. So those two things can actually be mixed. I realize there may be some colleagues who are from other countries as joining, although it's 98% Filipino, there will still be 2% from other countries in the Western Pacific. So it's important for us to look at our national guidelines, the national context. For the Philippines, I can say that the current, as of today, August 3, the situation is the facility isolation is preferred over home isolation. And the only time that patients are allowed to home isolate would be based on their symptoms, usually the mild to asymptomatic ones. And with permission, again, with explicit permission of the healthcare provider. They do have a checklist. You have to have your own room, your own bathroom, and many other things on that checklist. Now, in other countries, the situation might be different. So as Drs. Gary and Dr. Sophie mentioned, it is possible for the physician or the healthcare worker to order a transfer to the home, but to continue isolation. But in the event that isolation is discontinued, then it will no longer make sense to lock yourself up inside your room. So two things to look at: where you are going to be and whether you still require isolation. What the WHO guidelines refer to are whether you still require isolation. All right? So the time is 12:05. Thank you so much for many questions. That means there's a lot of interest. As of this point, there are still 493 in the Zoom room. And this is actually a record, Dr. Sophie and Dr. Gary. In YouTube, there are 47. So practically, there's around 550 on the first day. Please don't forget, everyone, this is just the first of 5 sessions. The other sessions will be on oxygen therapy and clinical care. That's tomorrow, Tuesday, by Dr. Vanessa Yap Yakapin. All times are 11 o'clock in the morning, Philippine time. That's GMT +8. On Wednesday, August 5, the topic will be co-infections and the use of antimicrobials by Dr. Jyoti Somani. On Thursday, August 6, the topic will be patient safety and healthcare worker infection and prevention by Professor Hokian Tan and Ms. Tang. And on August 7, it will be on the role of primary and community care in the overall COVID-19 response by Dr. Donald Lee. So wherever you are in the Philippines or elsewhere around the world, we hope you are safe and you are fine, and we wish you well for the rest of the day. See you again tomorrow, 11 o'clock. Check your email. It's going to be the same link. Don't worry, the same Zoom link. YouTube should automatically catch you in case the Zoom room is full, but not to worry. We will be sending out copies of the slides and also the footage of this webinar at the end of the day. Thank you so much and have a great day. Bye.